Dear friends, I'm Apalla, and this presentation is about dermoscopy in periocular lesions. The periorbital area is considered extremely sensitive both in terms of cosmesis and functionality. It can be affected by malignant and benign tumors, and in the former group, basal cell carcinoma is the most common one, accounting for up to 96% of the cases. This carcinoma has been associated with unique complications and side effects, as well as with a higher recurrence rate as compared to their cutaneous counterparts. With that said, it is reasonable that early diagnosis is the cornerstone of optimal management. But how early is early for the eyelids? In this study, Christian Navarrete and his colleagues concluded that periocular keratinocyte carcinomas larger than 8.5 millimeters might require complex reconstruction. This means that in order to make our life easier and our patients happier, we should be able to diagnose a basal cell carcinoma not at this stage or at that stage, but in this very early phase with a small lesion, allowing a very easy surgical approach and a good cosmetic outcome. In this systematic review, the authors found out that basal cell carcinomas mostly affect the lower eyelid and they are of nodular type, whilst sclerosing BCCs are very rare with only 25 cases in total. Which is the role of dermoscopy towards early diagnosis of a basal cell carcinoma of the eyelid area? The data in the literature are scarce. We don't have many data with only 3 studies. This is the first one in which the authors found out that the vessels in basal cell carcinomas of this area are not only of arborizing type, but can be also curved, linear, irregular, and sometimes they are seen as linear vessels in a perpendicular manner to the eyelid margin. If the lesion is pigmented, we may also see pigmented dots and globules. In this second study, in which the authors included not only malignant lesions but also benign ones, they found that ulceration and alteration in the eyelash growth were observed significantly more often in malignant tumors. Here you can see some examples of clinical and dermoscopy images of this study with the alteration in eyelash growth, structureless pink areas, perpendicular to the eyelid margin vessels, and steri-milia-like cysts that correspond to the pattern we see in BCCs of the eyelids. The steri-milia-like cysts is a criterion that you may also find in the literature with the term May globule. Here you can see it in a higher magnification. In this very important study, the authors tried to find clinical and dermoscopic criteria towards discrimination of basal cell carcinoma and dermal nevus, which is, let's say, the most common mimicker of a basal cell carcinoma of this area. And they found out that dermal nevi are seen exclusively on the mucocutaneous junction, whilst basal cell carcinomas can be found in both the junction and the eyelash line. The color is brown most often in dermal nevi, whilst skin colored to pink hue is seen in basal cell carcinomas. Regular surface is always seen in dermal nevi and irregular surface is seen in basal cell carcinomas in 6 out of 10 cases. Eyelash disruption, we never see eyelash disruption in dermal nevi, but it can be found in 4 out of 10 cases in BCCs. Globules, brown globules are found in dermal nevi, but arborizing vessels, which is a clue for a basal cell carcinoma involving other areas, it cannot exclude a dermal nevus since it can be found in 1 out of 4 cases also in the scenario of a dermal nevus of the eyelid. Here you can see a typical example of a dermal nevus on the right and a basal cell carcinoma of the eyelid on the left. For the basal cell carcinoma, we can observe the presence of pink background arborizing vessels, disruption of the eyelashes, and these are clues suggestive of basal cell carcinoma, whilst in the scenario of the dermal nevus we see the brown background and the regular surface with no alterations in the eyelashes. Here is a patient of mine with a basal cell carcinoma, lower eyelid, anterior margin, irregular surface, eyelash disruption, peak background, in focus arborizing and linear irregular vessels, suggestive of basal cell carcinoma. Here is another one, the same irregular surface. We see also the loss of eyelashes, which can be found in the literature with the term mandarosis, pink background, and the involvement of mucocutaneous junction, all criteria that suggest a basal cell carcinoma. A rare case of a sclerosing BCC involving both eyelids with the pink-white background, and we can see also arborizing vessels. In this case, we also see brown coloration, but in a structural manner that is not supporting, let's say, basal cell carcinoma. However, this was a case of a sclerosing BCC. As we said, this type of BCCs are rare in the eyelid area. Here is a mimicker, a dermal nevus mimicking a basal cell carcinoma. However, we can see that the upper eyelid is involved. We can also observe the presence of brown globules at the periphery of the lesion, and we see that there are no alterations in the eyelashes, and also the surface is very regular. The rare scenario of a pigmented BCC involving the upper eyelid, a patient of mine, with the use of our dermatoscope, we have a straightforward diagnosis with eyelash disruption, an erosion, and blue-black ovoid nests. Speaking about pigmented basal cell carcinomas, I would like to stress out that the scenario of a blue papule or a blue area patch on the eyelid is not suggestive of a specific diagnosis, can be seen in both malignant and benign scenarios. Here we see bluish papules that correspond in the first photo to hydrocystoma, second hemangioma, third blue nevus, accumulation of melanophages in the last one. And of course, not only these entities, but also pigmented apocrine hydrocystoma in this photo, and also apocrine cystadenoma in this photo. As I said, it can be seen also in malignant scenarios, and here it is really an identical to the previous lesion, a bluish papule, but this time it was a basal cell carcinoma, and also this time it was a basal cell carcinoma. So if you don't have specific diagnosis, please proceed with excision, because we don't want to leave a basal cell carcinoma growing on the eyelid of our patients. Of course, if you have access to confocal microscopy, you can perform confocal, because it gives you many useful information towards correct diagnosis. A last comment I would like to make is about the margin of a lesion. This patient was sent to me by a photo from the surgeon asking me if I agree that this is the correct clinical margin of the lesion. And I said, please send the patient to my office to check it by the dermatoscope. And we did so, and we found out that this lesion was not of that small size that was able to identify the oculoplastic surgeon initially, but it was much bigger. Take-home messages: disruption or loss of eyelashes, irregular surface, and erosion ulcerations are suggestive of a BCC. Arborizing vessels can be present also in dermal nevi in 1 out of 4 cases, and other benign lesions. Homogeneous blue nodular lesions need histological examination, since they may equally correspond to both benign and malignant tumors, and in the end, dermoscopy may facilitate margin recognition. With this blink with a dermal nevus and a basal cell carcinoma kissing each other, I would like to thank you for attending this webcast.